we started talking about at first access. So if you're having clinical research happen in the cloud, does that automatically make it more accessible to people, or does that exclude different population groups? So we had discussions around people having access to technology by way of having good enough internet access, having the capability to do something online, as well as whether or not they would have the equipment to do it. So I thought that conversation was really interesting, but maybe got a little bit less about the actual cloud and a bit more about how you would set up something to work for a particular population. So whilst that's interesting, I got really interested in the conversation about e-consent and how using different systems and different technology solutions could actually make sure that you would have people understanding the information better. So I think we've got a bit of a cognitive bias towards it's harder to understand stuff when it's electronic, and you'll get much better understanding and a much more valid consent process if you've got a person talking to a person. But there's all these sorts of new technologies now that can present information in more accessible multimodal ways, can facilitate having information in different languages, make it easier to use translators, and even would want to know that there's options for creating consent processes where quizzes can be built in, so comprehension can be tested. Taylor was talking to us about some systems that will, if you've clicked yes I consent too quickly, it will put you back in a loop of sorry, you actually haven't had time to read this, so please read it again. Using things like multi-factor authentication too, to make sure that it's the same device that's accessing the system again and again. And so that was really interesting, and it was about being able to, because the question we had was what would you need to know about trial activity on the cloud, is that how do you explain to somebody about what will even happen in that process, how good do your technology skills have to be in advance, and what skills will the trial staff actually need to have to manage it all. So was there anything else major around that I've just missed out? There's lots of rich conversation. So probably the most sensible thing to talk to next was, once you've got somebody who consented to a trial, that then we've got to worry about, well, where is the data, which cloud? Is it clear to everyone involved about whether or not that data is held in Australia or overseas, because that changes the regulatory environment, the legal environment for the data. You've got to know how long it's kept, in which format it's archived, and so understanding all of this is probably, it requires different skills and different personnel too involved in trials. Then we talked about secondary data use as well. We had interesting and existential conversations, I think, about we have so much data, is it an ethical problem to be not using data that's available in the public domain? Is it unethical not to be tapping into our repositories of data at hospitals to understand what we already know about something before we go and do new research, which went a bit off topic, but was very interesting. And then talked about thinking about the risk once something is happening in the cloud and doesn't look like a traditional in-person kind of way of running a trial. Is that automatically more risky? Is having your data shared electronically more risky than having it on paper? So really fleshing that out is really important to know. And who has access to and owns the data? We talked about understanding, making sure it's really clear for workflows for all different actors in a trial system, patients, for everyone, to really understand what that workflow looks like. So I think we're all a bit more comfortable because it's very familiar to know what it would be like to go to a hospital site and go through all the processes. Even though it's really important to understand a workflow, if we're going to do things in the cloud, more important to be explicit, really explicit about and map out all the workflows, all the different options, and make sure that different options for flexibility are really understood. And that can make it much easier for ethics committees to be confident that it's going to be clear to everyone how data will be used, how people can interact, and where access issues might come up, or where other issues could come up. There was more about ethics. Trina, do you have anything to add on that? Because I don't want to misrepresent or forget.
No, I think you covered.
Yeah, I just thought what we needed to know, it seems like too, for ethics committees, whilst technology is changing at a really rapid pace, just to have more information than less about how things will be handled and what the workflows will look like for different people. We talked about bias and equity and access, and understanding that it should be not different just because it's a cloud-based way of running research, but really understanding who something is for and who it's not for. If you're doing it this way, who is likely to be able to manage it, who is actually able to manage it, so who does that include and who does it exclude? So we can't say that just because something is going to happen cloud-based and a person can go on the internet and put their stuff in, that makes it more accessible for people in regional areas if there's no internet access. Oh, we talked about being able to think about AI and using AI to standardize and to also assess how acceptable different devices are going to be able to say, well, this is a source of accurate data. So I have a colleague from ophthalmology trials looking at just understanding what kind of image quality would you need for something, and balancing, I guess, access with all different types of newer devices with, if you only have something that's extremely specialised, well, is that going to limit access to people in your trial? Yeah. We talked about a lot of different things.
Everyone that visited table 2 on the body. There are a lot of considerations, many of which have been covered already in terms of in the cloud, but as I relate to on the body, I'll mention them again. Lisa, I can help translate if I'm not able to read down the track, but I'll start perhaps here. So actually, Sarah, it was you that brought this up in terms of providing participants with their individual data back, so the results from their wearable. So there are lots of considerations around that, of course, and it isn't actually always going to be possible to, because of de-identification and re-identification and you know, but in an ideal world, that should happen 100% of the time. That's that patient's data, and it should go back to them. So that's a consideration. Data security and privacy, you can see there's a bit of a thought bubble here, and then lots of different points off that. So I'll hopefully cover them all sequentially. So one of the aspects that we should consider is where is that data stored? What happens if it's hacked? Is it geolocated or tracked? The ability for patients to opt in and opt out of specific data collections. Are there patient-reported or self-reported things being collected in parallel, you know, as backups or, you know, as support? Is there validation going on between those? Who is the custodians for the data and for how long? Who has access? Can access be bought? So is that part of a larger database that can in turn be bought down the track? And is there a way to future-proof against that? Again, as I mentioned, de-identifying and then re-identifying. Is that re-identification piece possible? It's important to prevent against that. I think. So post-trial data collection is obviously a no-no. So if a patient has been gifted a device, and Apple Watch is a good example, the sponsor shouldn't continue to collect data after the trial has come to an end. But on that point, continuity of data collection is important throughout the trial, and setting up those definitions from day one in terms of a control or a baseline, and defining at what point you need to collect data in advance, and doing so. The scope of the collection, So again, getting back to an Apple Watch, you know, the ability to collect 500 different data points, but if a sponsor's only interested in 2 inputs, should they actually be collecting so much data? Should that be limited or expanded? And actually we had long conversations about that, because sometimes more is more, and it's nice to have that data in the future, but yeah, there are lots of considerations around that. I'll stop going off on tangents. Okay, so this one was around risks, so specifically related to implants, and there are lots of considerations here in terms of the risks around implanting something and then removing a device, or you know, whatever the implant might be, considerations around discomfort, inconvenience, like when you're prevented from showering, for instance, or you know, because you need to wear something like a backpack that's transmitting something, or you need to be near a base station like your home, so you can't sort of leave your home for a certain space of time. So yeah, there are lots of considerations around that. We also talked around in terms of an implantation and you know, a surgery occurring, the need for an MSL type person to accompany a surgeon into surgery, and considerations around that, because sometimes it's not always very comfortable for a surgeon, and certainly not their what they're comfortable with, or what they prefer, and also what happens if something goes wrong in surgery. Like a surgeon would be comfortable with their team, and they would kind of be able to predict how they're likely to behave if something did, you know, an adverse event did occur, whereas perhaps someone like a third party, you don't know how they're going to react in that instance. Translation, is Google okay? Need for translation, interpretation, validation, probably covered that a little bit already, or you will in other sections. Where else? So we got the covered tech transfer, cloud. Postage was a big one in terms of returning the device. Really important to make that as easy as possible for the patient, and actually that's a really good way to behave in general. Everything should be made as easy as possible for the patient at all times. BYO device, so that's another consideration. So patient already has the device, and we can assume that sometimes for some devices such as iPhones or phones in general and watches, that actually it might just be an app that you're downloading. That in turn brings lots of different considerations around compliance and other things. What else have we got here? Telehealth, recording, consent. I should probably talk about that, because that's actually perhaps where I should have started. And again, that relates back to data security and privacy, but consent has to be appropriate and at the right level, and providing information that's actually relevant and applicable for the patient, but obviously not completely overwhelming them as well. So Carrie and I, we were talking about this before, in terms of the patient, the information should be, you know, really in a form for the patient's benefit, rather than because you feel like you need to disclose certain things or cover yourself in some way. So we talked a little around validation, precision versus accuracy, calibration, risk-based validation. There's a whole lot that comes under that, but there are a couple of the headings that came out of some of our discussions. The need for education, so not only the patient in terms of using the device, but training the trainer, so training site staff who will in turn train patients, also training carers, because often they're really intricately involved in helping a patient to utilize a device, providing really clear and detailed instructions in addition, because often when you're told something at a site, you can be, you know, in a vulnerable state or a bit overwhelmed and don't remember a single thing, and so you really, like, some pictures that are very straightforward are just essential. Education as well around adverse events and you know, what to expect, what not to expect, how would you go reporting those, ensuring that that information's provided up to the principal investigator to really, you know, have that perspective over the whole trial, or, you know, his or her cohort of patients, to keep an eye on things. And then support if something goes wrong. So that's really critical, who to contact if something goes awry. And also that information, knowing who to contact, shouldn't just be available on your paper consent that you probably have lost. It should be available easily online. Some rules in place in terms of what happens if a device breaks, who's liable, how can it be easily and quickly replaced, etc. I'll leave it there. For anyone that contributed, these aren't my ideas, these are all of your ideas. So please, if I haven't done them justice, please feel free to build on them right now. Come up and...
So I might just add to that and just note, I probably mentioned at the start of the day, but just to add in before we move to table 3, there's quite a lot of CTIQ members who wanted to be here and weren't able to, and others of you in the room that will have been involved in conversations, and it'll spark new thoughts, or you'll have heard the reports back and you've drawn some links in your mind. Based on Jill's amazing inspiration from our last steering committee meeting, we're going to set up a mural board that we'll make available to all of you and all of our CTIQ members so that you can contribute asynchronously after the event. We'll include pictures of all of these we've reported back from, videos that Alison has been creating, and you'll have opportunities to add additional information then. So don't feel like just because something hasn't risen to the top of the discussion in this room today in a way that you wanted to, the opportunity to contribute and draw links doesn't stop you.
I think there's also one other consideration which I should have mentioned, which is there's some guidance that exists globally already, so drawing on some of that. I know City have produced some work in this area around wearables, and there's information out there in various jurisdictions around DCT, so not reinventing the wheel when we don't have to, but again, making sure that it works for us here in Australia.
We're talking about activities in the home, and we had some great suggestions come on the post-it note form, which was fabulous, and that really, I think, was directly supported by the discussions that occurred on the table as well. Lisa very nicely did a visual. Great, thank you for doing that, because I'm not a visual person. I'm a list person and a person who doesn't write very well, so it's a bit kind of difficult. But I think there were kind of 6 main themes that came out of the discussion that was on that table. They were kind of around safety. So we were talking about safety of the staff that go into a patient's home, about what they might be walking into, and how that can be addressed or assessed and dealt with up front. We were talking about the arrangements for staff that don't normally go into a person's home because they're not part of an outreach kind of service, and what that means in terms of their employment and if something goes wrong. But also in terms of safety of the person whose home you're going into. And who is coming, how often are they coming, how many people are coming, are these people that are kind of in addition to the GP and the pharmacist and all these other people, and so they're having these people trooping through. And secondary to that, I think, was a bit of a discussion about, with all these people trooping through, what kind of a burden is that onto the family in terms of just, do I have to clean the house before someone comes in? Do I have to have tea and coffee and milk available? Have I cleaned the bathroom? Those kind of things that, for people who visit patients in the home don't think about because it's just not on their radar. But for people in their own home, that might be a problem or an issue and an additional burden that's not necessarily, something that they should be worried about. So I think that kind of covered some of the safety issues. We talked a bit about location, and we've been talking about patients' home, but it's not only home. Somebody very naturally put up on here a driveway, which I thought was, really blowing it open, because what we're doing is talking about a location that's not a health service, not a a hospital, not a GP clinic, but it could be a location that might be their caravan or their room in the residential aged care facility, or it could be anywhere else. And so you just need to kind of have consideration about where that visit or that study location of the person is, and at all times respect what that is and where it is and the rules that are kind of around it. What's my list here? I think what turned out to be kind of in the middle, which is interesting itself, is just flexibility, which is kind of good because that's what today's all about. So it was just about, making sure that the arrangements for there being study activities in the home are flexible. It revolves around the patient or the person who's participating in the trial and the people that are around them. And that flexibility needs to be brought in at the stage of the protocol, in the minds of the people who are collecting the data and seeing the patients, to make sure that this is truly about the patient and it's not at our convenience. And I think, yes, you have it in there too, so that's good. Another idea about the flexibility was related to wearables, and the data that we collect in the home, we can introduce flexibility in terms of having wearables or devices or other kind of collection of data that maybe doesn't involve having someone barging in through someone's front door, but thinking a bit more outside the square and potentially thinking a bit more outside the funding, to have some kind of wearable device for collecting data. And Taylor, thank you for your insight in saying, well, instead of paying for patient transport, we can use that allocation of the funding to pay for their data and those kind of payments, which I think was fabulous to be able to think about the kind of budget lines a little bit differently. One of the other items that we talked about was about choice, and that was discussed in terms of making sure we provide options for people. It doesn't have to be, again, a visit to the home, but it can be from the home, like videos, phone calls, text messages, those kind of choices, and ensuring that those choices are presented to participants to allow them to provide their data in a variety of different ways from their location. And then we were talked about trying to account for diversity in terms of time and place. We did have a bit of a discussion about consenting and translation of consents within people's home, and I know that's a much larger discussion potentially for another day. I mean, there's lots of little bits in here, but I think they all kind of congealed into those kind of 6 things. But BusyTown started with a question which was, does BusyTown have the capacity to deliver a clinical trial or clinical trial services? And it ended much later, an hour later, on is BusyTown a site? And that conversation essentially went around three major themes, which was based around the people, the places and the processes that need to be in place to offer trial services to people of the town. Where the majority of our conversation landed on was that the services, trial services for any location really pivot around a person. Much of the infrastructure can be, it might be complicated, it might be expensive, it might not be done yet, but much can be delivered remotely or can be outsourced in some way. But it does require at least one person, preferably a health person, to be in that town to be able to deliver the services. The problems associated with that are whether there are specialist staff available, the itinerant nature of some of the staff if BusyTown is actually in a rural location, the reliability of that staff member to have access through this fancy little smartphone, which you'll like here, through this data line that then has gossip often in a rural town, privacy concerns, to an expert somewhere else if they are not appropriately expert. The places in this town are possibly not as developed as they would need to be. There's other services that you're needing to loop in with. This is the high street here. It has education, it has a pub, it has a library, and it has a community centre. It has all of those things because in locations where the health services are not developed enough, there's our reliance on some of these to provide the locations and the infrastructure for people to access even basic healthcare and then additional healthcare like trials. We felt it was fairly dependent on education, and education both ways, both to the community and to health service people. There's a significant question on who is going to deliver that education to people, and that education is not necessarily only based on clinical trials, but sometimes it actually needs to come right back to some education about healthcare and what healthcare means and what is available to people. All of it costs money. There's different funding sources, as we all know, that support an entirety of a town, from local government, state government, federal government, and then some of the funding that supports a town, which is often quite unique to that town. And then we landed on, if BusyTown is a site, what is the plan B for when staff leave, when you need clinical escalation, and when you need clinical oversight? That's a very quick summary of an hour's conversation, and an incredibly complex determination. This is McDonald's, because there was a bit of discussion where in many smaller towns, McDonald's does actually provide a fairly important service for access to Wi-Fi and locations for people to access data. I haven't covered even remotely everything, but I know what it's like when you're needing to get to either flights or children. So that's the summary, essentially. Pivots on a person. It's very complex, particularly the funding aspect of it, but also particularly if you're going to call it a site or not.
All right, I am going to do like a really quick summary because a lot of what we talked about is stuff that's relevant to the other sites. The thing that's different about if you're going to a clinic, which is what our site was, is you're going to somewhere where there's a different business as usual. So they're people who are already doing their own jobs and you're asking them to do additional stuff. So one of the things that came up was that you're asking them to blur the line between standard care, what their clinical care is, and what research is. So getting those relationships solid with the site people, spending the time building those relationships and getting the buy-in that doing research at that site is important and it's worthwhile was really key. And thinking about why are you doing it at this site? So what's the purpose of using this system? What is the problem that you're going to solve? And is doing it at this site actually going to solve that problem? We went into a lot more detail, but I'm not, you'll have to see the recording.